In Chapter 23, we're going to be talking about postpartum complications. A lot of this you may be familiar with from when we discussed postpartum in the Unit 2. We're going to expound a little bit more, and a lot of focus is going to be on postpartum hemorrhage because that is such a significant concern and complication that happens with childbirth. So why am I going to spend so much time talking about postpartum hemorrhage? Because it continues to be the leading cause of maternal morbidity and mortality. So it takes a pretty significant rank in postpartum complications. When we try to determine what is a hemorrhage, first of all, hemorrhage is not a diagnosis. Hemorrhage describes an event that happens in relation to postpartum period. Traditionally, we'll say that for a vag delivery, anything over 500 milliliters of blood loss within the first 24 hours constitutes hemorrhage. If it's a cesarean birth, then we will go up to 1,000 milliliters of blood loss. If you see a 10% drop in the patient's hematocrit, which is why you always have your baseline H&H and you always do one pretty much day 1, day 2 post-op for comparison. If you have any cardiovascular compromise related to any amount of blood loss, that constitutes a hemorrhage. So there are, different parameters that you can use to look at. What we need to remember is almost universally, estimated blood loss is sometimes significantly underestimated. It is rarely accurately estimated, and I would say almost never overestimated. So blood loss postpartum almost routinely underestimated. We pretty much determine or classify hemorrhage as it relates to delivery. So, primary, early, acute onset, whichever term you want to use, that's going to happen within the first 20 hours of birth. After that first 24 hours, through at least 6 weeks postpartum, that is going to be secondary or late. Keep in mind, we'll talk about later, infection is one of the leading causes of delayed or secondary postpartum hemorrhage. Not all infections will necessarily manifest themselves within that first 6 weeks. So there is consideration to extending the concept of that postpartum period out to 12 weeks. We are sending people home earlier and earlier nowadays, and we think we're being good. There's no complications. Mom's doing fine. Baby's doing fine. We think we're just letting them get home and get settled into, life as a new family. But when you think about the high associated risks that go along with postpartum hemorrhage, it may not be a good idea to send them home. We used to keep people in the hospital 3 to 5 days. Now we do good to keep them 2 to 3 days. And so when you think about it being the leading cause of maternal morbidity and mortality, postpartum hemorrhage is not anything to play with. And sometimes sending these people home isn't always the best thing. Well, if y'all haven't learned anything else, you've learned that uterine atony is the #1 cause of postpartum hemorrhage. But there are other causes and really the uterine atony is the cause, but the other things can be associated with the uterine atony. So anytime you have retained placenta, placental fragments, or products of conception, a lot of times that's going to prevent the uterus from clamping down, but it can also, especially if it's products of conception, lead to infection, which can cause postpartum hemorrhage. If you have lacerations, and it can be cervical, vaginal wall, perineal, anything like that. If the mom has any coagulopathies, maybe there is a DIC from HELP syndrome, or she just has an issue with clotting. And we'll talk about clotting abnormalities a little later on. Uterine inversion or rupture We'll talk about something that could actually cause the uterus to be turned inside out. And then remember, we talked about the significance of uterine surgeries and any scars, repairs, or anything, how that weakens the integrity of the muscle, so you could have a rupture. If the placental site does not heal and involute properly, remember the placental site has its own unique healing and recovery time and process, so it might have difficulties. If that doesn't heal up well and involute, will have infection, which can lead to uterine atony, and then just infection in and of itself, any type of endometritis. So those are some causes of your postpartum hemorrhage. All right, so if we say uterine atony is the #1 cause, well, where are we getting the atony? What's causing the uterus to not tone up and firm up? So remember, just for definition purposes, that uterine atony is marked hypotonus of the uterus, okay? Marked being in big, bold red letters. So what can overdistend the uterus? Well, if you have an excess of amniotic fluid, so you're polyhydramnios, well, what situations might you expect that? If you have a multifetal pregnancy, so you've got more than one baby in there. If you have a mom who is diabetic, you have a fetus who is large, worrying about diabetes, so you can have the polyhydramnios with that, and you get a big baby. So you almost get a double whammy with something like that. And then think about clots. At postpartum bleeding, where that placenta detaches, that site's going to be bleeding. But if you've got a clot that is blocking the outflow tract, then your uterus is going to distend because it's filling up with blood, and therefore it's not going to be able to clamp down. Your medications that are associated with hypotonus of the uterus, your mag sulfate, because it's a relaxant, right? Your Pitocin, and you're thinking, well, Dr. S, Pitocin we use to make the uterus contract. However, there are a finite number of Pitocin receptors on the uterus, so if you saturate those and you don't have time for the body to clear it out, then you're going to actually have a counter effect. So Pitocin might have some association with your uterine atony. Again, the chorioamnionitis, so if we have an infection, think about this woman. If we're supposed to be doing fundal massage, uterine assessments, think about the patient who's got an infection in the uterus. She's already not going to be acting right tissue-wise, okay? The processes aren't doing what they're supposed to be doing. But she's also going to be in pain, and she's not going to want you assessing and doing massage on her. So you almost have a double whammy of negativity there. And then if you have an assisted vaginal birth, a traumatic birth, so it's not just the forceps, but even the vacuum-assisted deliveries, those all have potential associations for uterine atony. So I said we'd talk a little bit about the uterus and how we could have some inversions of it. Well, if you have a difficult third stage, which if you remember is the delivery of the placenta, any thing that poses difficulty in third stage has the potential to enact a postpartum hemorrhage event. You should never pull on the umbilical cord, okay? You may have a little gentle counter pressure, but you should not use intense traction pulling on the umbilical cord to deliver the placenta. And you have to watch for those hallmark signs that says your placenta is detaching and ready to deliver. So remember, you're going to see lengthening of the cord, you're going to see that gush of blood, you're going to see the uterus change shape. That should tell you that the placenta is about to deliver. Then you can assist the placenta out, but you should never pull on it because you could actually invert the uterus. Subinvolution is going to occur, as I said earlier, if you have retained placental fragments or products of conception, depending on how advanced the pregnancy was. And if you get a pelvic infection, so an endometritis or anything. What can cause retained placentas? What can lead to a difficult third stage? Well, your placenta attachment and the depth to which it attaches can play a pretty significant role in this. And the unfortunate thing is you may not know this. So when you're going in to deliver, how deep the placenta attaches, you're not necessarily going to know, but your cue is going to be when the placenta doesn't deliver the way it should. If it's taking more than 30 minutes, we have an issue. So what are the placental attachment levels? You have a placenta accreta, an increta, and a percreta. So we know the placenta attaches to the endometrium, but if it is attached improperly, then it goes to the myometrium. With an accreta, it superficially attaches to the myometrium. So accreta, the A, pairs up with attaches to the myometrium. So A to A. Placenta increta invades into the myometrium. So the I of increta goes with the I of invades. Increta invades. And then percreta actually penetrates through the myometrium, so you've got P to P. So accreta is into the muscle, or superficially attaches onto the muscle. Increta invades into the muscle, and percreta penetrates through the muscle. So you can imagine that if you've got a placenta percreta, it has penetrated through the myometrium, and that placenta attaches to an extrauterine structure like the bladder or bowel or something. That's not going to deliver, okay? And if you try and force it, that's where you're going to start having placental tearing and fragmentation. The unfortunate reality is when you hit one of these situations, it is pretty much always going to be a surgical recovery process, and the woman may end up with a hysterectomy because it may be impossible to salvage the damaged muscle tissue. So I put this picture in just to kind of give you a visual of what I'm talking about. So if you look at the bottom, the accreta, you can see to where that just superficially is attaching onto that myometrium, that muscle layer. If you go up, you'll see the increta, and you can look and see how that placenta has invaded into that muscle layer. And then if you look at the top at the fundus, the percreta, you've got that placenta penetrating through that muscle layer, and it is actually going to attach outside of the uterus. So you should be able to look at this and then even further visualize how damaging it would be to try and deliver this placenta manually, and the fragmentation that your placenta is going to go through. And if you have a full-blown percreta, how that may damage the uterus so much that it's not salvageable. All right, so do you think you're always going to be able to just obviously know someone's having hemorrhage? Well, in a perfect world, you might be able to see it, know it, react upon it, minimize it. However, you don't always know that a woman is hemorrhaging by seeing the blood. Think about the woman who has the clots blocking the blood's escape. So her uterus is going to be changing, it's going to be slowly filling up, distended. She's not going to have a frank bleed that will say, ooh, hemorrhage. So how do we know when a woman is having the potential for a hemorrhage, bleeding a lot? Well, you're going to look at your assessment information, okay? You're going to look at your vital signs. You're going to look at the level of consciousness, the skin, and the output. So here you go. Heart rate, what's she going to be? Well, think about your compensatory mechanisms. She is going to be tachycardic first. Respirations initially are going to remain the same. Her blood pressure initially will remain the same. If you wait until you see hypotension, you have waited too long, okay? Tachycardic, normal respirations, normal blood pressure initially. If she is having distension from the clot, she is probably going to be experiencing pain. If she has a hematoma forming where the blood is collecting in the tissue, she is going to have pain. She's going to just give you the I'm hurting, pain medicine's not touching it, something doesn't feel right kind of job, okay? So tachycardic, normal respiration, normal blood pressure, pain, early signs that you're going to be looking for. Level of consciousness, initially, she's probably going to be agitated, irritable, fussy, fidgety, maybe even would almost seem uninterested in the baby because she is so uncomfortable herself. Remember, if she's bleeding, then we're not perfusing oxygen, we're not giving oxygen to the brain's trying to get your attention. If you wait until late signs of somnolence, loss of consciousness, obtunded, you've waited way too long. Skin, it's probably going to be cool to the touch, right? Because it's not circulating as well. We're shunting blood to our centrally, so not to our periphery. You may see paleness. I always look at the lips. When people's lips start turning pale and almost white, you know there's an issue. And then, do they have that wide-eyed, almost scared look to them? Okay, so that's something you're going to worry about. And then output. I'm going to tell you, urine output is a great assessment of perfusion because, like we talked about with the MAG, if you are circulating and perfusing your kidneys and putting out, 25 to 30 cc's an hour, that's pretty adequate, okay? So if you have a drop in your urine output, that's going to be an indication your kidneys aren't perfusing. Why are they not perfusing? Because I'm bleeding out and the blood that I do have, I'm shunting to my vital organs. You also want to look at the color of your urine. If it is A, blood filled, think about if you've had a cesarean birth, did you nick the bladder or something? But B, if it is getting darker and more concentrated, then that's going to be a volume issue. So those are the signs and symptoms that you're going to look at that will alert you to a hemorrhage development without actually having to see the blood. All right, so if I do see the bleeding, well, what do I need to do? Well, first of all, you've got to determine the site, okay? Now, where does blood flow? It flows down, right? Gravity's going to take it down, so it's going to be probably even underneath her. So you can't just pull the peri-pad back and look at the peri-pad to say, oh yeah, you're bleeding or not, because the blood doesn't run up the pad, it's going to run down and it's going to pull underneath her. So you may very well need to actually lift her up, roll her over to be able to see where the blood is. You're also going to look to see if you can determine the source of the blood. Is it a perineal laceration? Does it appear to be a vaginal laceration? If you can't see it, it may be a cervical laceration or even retained placental fragments. The provider should look at the placenta when it's delivered, but it doesn't, it doesn't always happen, unfortunately, and something could be missed. You want to look at the color of the blood. Is it bright red or is it deep red? Is it constant or is it intermittent? Is it gushing? Is it trickling? Okay, and is there an odor to it? And really the odor is going to come more if there's an infection that you're worried about. Lochia is going to have a natural, for lack of a better word, human, almost maybe musty kind of scent. That's just a natural thing. An infectious issue is going to be malodorous. We want to quantify blood loss as much as we can because we said within that first 24 hours I can only lose 500 with a badge or 1,000 with a cesarean. So if I am soaking through pads, how do I know how much blood I've lost? Well, you take the dry weight of a pad or whatever product you have to suck up the blood, you subtract it from the wet weight of that same product, and then how much weight is in there, what the balance is, will be the grams of blood that are in there. To convert that to a volume, 1 gram of weight equals 1 ml of fluid. So you can actually determine closely how much volume is in whatever your soaked product is. Anytime you have bleeding, you need to assess the site, and you need to know how many peri pads are used, okay? So really in women's health, anytime you have a bleeding presentation, whether it's in a doctor's office, whether it's in an emergency room, whether it's in a hospital triage or outpatient, wherever, if she comes in and says she's bleeding, you need to see where the source is, and you need to know how much, because when you call the provider to tell them, they need to know their decision processes will be made on what the current status is. You also want to identify, are there any clots or tissues or fragments or anything like that in the blood that you see. All right, so when you are assessing the source of the bleeding, we all know that uterine assessments are very important. You always want to look to see, is the uterus firm? Is it midline? Is it displaced? If it's displaced, why? You know, if it's displaced off to the side, or even if it's elevated, you're going to do a bladder assessment, because if you have a full bladder, then that is going to displace your uterus, and it's going to interfere with the uterus's ability to contract down. But you also want to check to see if the uterus is distended in any way, if there is any pain or tenderness or any rigidity to it that would be associated with an infection or a rupture or something like that. Look at the perineum. You want to make sure that you can identify any tears if they are present. Again, where are they? Are they vaginal or are they cervical? See if you see any hematoma formation. If you see hematomas forming, or if you see one, more than likely that's going to be a trip back to the OR, because she's bleeding into the tissues. So you have to stop the source of bleeding. So the provider may very well do, it'll be a smaller surgery, but they will need to open the area up. They'll need to evacuate the clot. They'll need to identify the source of the bleeding and stop it. If there are clots inside, then the provider will need to be called, because they will need to expel the clot. So when you do fundal massage and doing the uterine assessment, you're going to look to see, okay, am I expelling any clots or not? But if you're not able to expel any and you feel like she's full, the provider may need to go in and do a D&C. Depending on how soon after delivery it is, they may do a manual evacuation of the clot. All right, so now that you have gone through the identification, signs and symptoms, bleeding, source, site, such as that, you have to treat it. There are 4 drugs that we use to promote uterine tone and to manage and or prevent a postpartum bleeding event. Oxytocin or Pitocin is your first line drug. Every woman's going to have it. You're going to have a mix of anywhere from 10 to 40 units in 1,000 cc's of either saline or Ringer's. It'll be a continuous infusion. However, we talked about oxytocin or Pitocin can actually lead into some bleeding issues, and that's because if it was used too much in labor for either induction or augmentation, you may have oversaturated the uterine receptors, and so the Pitocin isn't being effective. So you have to have your next go-to drug. So the other 3 options that you have are your methyl ergonovine or your Methergin, your carboprost, which is your Hemabate, or your misoprostol, which is your Cytotec. I'm going to say the trade names just because in talking they're easier. Your Methergin, it's going to be given IM, not IV. Make sure you keep that straight. 0.2 milligrams. You're going to give the first dose. If you don't see any result from the first dose, and you should see it pretty quickly, you can dose it again, but you're probably not going to get an effect if you didn't get it off the first one. Your Hemabate is 250 micrograms. You give that either IM, or you can actually give it into the uterus itself, so intramyometrial. Hemabate is not given IV. So your Methergin and your Hemabate, you can give them IM, you do not give them IV, okay? you should see a pretty fast response from the Hemabate if you're going to give that. Now, you have to remember you can't exceed 8 doses in 24 hours. Your Cytotec, your misoprostol, this is your prostaglandin drug. Remember, prostaglandins stimulate uterine activity and contractions. There are different ways to give it, but rectally is going to be a very fast response. You can give it orally, you can even do vaginally, but if you do it rectally to manage a postpartum hemorrhage event, you should get a pretty quick result. And the dosing for that is 800 to 1,000 micrograms rectally. So in the slide here, what I've shown you are just the different side effects that you can get with the different medications. But what I want you to be aware of and to think about are the contraindications for giving the drugs. So with your methyl-ergonabine, your Methergin causes your blood pressure to go up. That's a normal response to that medication. So if you have a woman who is gestational hypertension, preeclamptic, eclamptic, chronic hypertension with superimposed preeclampsia, or maybe even a normotensive woman who received repeated doses of ephedrine in labor to get her blood pressure up. Anybody that has concerns before you give it of elevated blood pressure, you do not use Methergin. Straight up. So you get that? Elevated blood pressure, no Methergin. Hemabate, or the carbaprost, the associated side effect contraindication with it is that it causes bronchospasm. So if you have a patient who has reactive airway, asthma, anything, even if it's an exercise-induced asthma, and she's not having any issues, because the Hemabate can cause bronchospasm, you do not give Hemabate to those patients. Now, from a nursing perspective, one of the nasty side effects with Hemabate is just profuse diarrhea. So be advised that if your patient is going to get this, that you're probably going to be needing to clean her up. And then with the Cytotec, nausea, vomiting, shivering, headaches, really there's not a lot of contraindications to being able to use the Cytotec. So for what I need you to know with these meds are why you would not give Methergin and why you would not give Hemabate. Labs that you may see ordered in this situation, I've split up for expected and possible. A CBC with specifically an H&H you can count on because they need to see, remember, a 10% drop in your hematocrit constitutes a hemorrhage event. Then you want to make sure that you've got your H&H baseline, and then you can see how much it's falling. You can also look at the white count. Now you're going to see a shift just because it's a postpartum, but are you seeing a correlating infectious shift? When you're looking at the blood, this is just a note for you. For every 500 milliliters of blood that you lose, your crit will drop about 3%, or your hemoglobin will drop 1 to 1.5. So you can imagine a 10% drop in your hematocrit equates to about 1,500 mLs of blood that's lost. So that should put it into a perspective of why this constitutes a hemorrhage event, okay? Your fibrin split products, remember the clotting cascade we talked about in the last chapter and the potential for the DIC. So you want to be checking platelets, you want to be seeing what the fibrinogens are. You want to have this person, you're probably going to do a type and cross. Type and screen just means, ABORH. Type and cross means you've got blood ready to give. And it can take 30 or 40 minutes to get units cross-matched. So if you've got a patient that you know has a risk for hemorrhage or you're worried about something going wrong, you might want to go ahead and get at least one unit crossed before things get started. If the possible labs, if you're bleeding out and you're becoming hypoxic, then they may do arterial blood gases to look for any acidosis. Drug screens, we said that cocaine use is one of the causes of placental abruption. Abruption is going to be hemorrhage, so you may look for a drug screen with that. You can do liver function tests. You can do Klein-Hauer-Betke's. Those are just your potential labs. So what are your nursing interventions in a hemorrhage event? Well, uterine assessment and intervention as needed is going to be pretty much key to maintaining homeostasis and preventing any hemorrhage event as it relates to the uterus itself. So assess it. If it is boggy, then you're going to do fundal massage and firm it back up again. Remember, you're going to have your order for your IV Pitocin, 10 to 40 units in 1,000 cc's, so you're going to give that. If you are having bleeding identified and the uterus is firm, well, what's going on? It's not bleeding from the uterus, so you have to identify where the bleeding is. Is it a cervical laceration? Is it a vaginal laceration? Is it perineal? So you need to identify it and then treat it. You can do, the provider's going to do the suturing and evacuation of any clots or anything like that, or if it's a hematoma, evacuate that. But the ice for the discomfort pain management with ordered meds, those are things you're going to do. Uterine inversion, the uterus is going to need to be put back where it was. So it's going to need to be turned, right side out and put back in place. That's not going to be the easiest thing to do. The provider may administer tocolytics. Terbutaline is a lot of times what they're going to use to relax the uterus. I mean, they can use MAG, but terbutaline is going to probably be their first go-to drug to just relax the uterus so that they can manipulate it and put it back. If you have subinvolution, first of all, you need to determine the cause of what's going on. Remember, infection is one of the big things that we have to worry about, so you may need to give some antibiotics to treat that. To help the uterus contract down, then the methyl-ergonovine, 0.2 milligrams, is probably going to be utilized for that. If there are any surgical procedures for really any of these, a D&C can be done to evacuate uterine content, and depending on the severity of what's going on, it may need to be a hysterectomy. If you look on page 728 in your text, box 23-2 has a list of herbal remedies for postpartum hemorrhage and the identification of what the herb is and the actions of that. I mean, witch hazel is something that a lot of people have heard, familiar with. That's a homeostatic med. Your blue cohosh is an oxytoxic, so people may use that. And your yarrow root is a homeostatic herbal remedy as well. So if she has had a hemorrhage event and blood loss to the point of hypovolemia and going into shock, then we've really got some issues. We have not been able to curtail and contain the blood loss effectively. So a hemorrhagic shock does become a straight up emergency situation, because she is going to become hypoxic. She's not perfusing her tissues very well. So, her brain, her heart, and her adrenal glands, we're going to try and perfuse those to keep us alive, but everything else is going to suffer from it. So the gut, the kidneys, liver, all of that is not going to be managed and perfused, so you're going to have some pretty significant outcomes. In a worst case scenario, she's going to die. We certainly want to make sure that we prevent that. You got to think about, the body is very smart. So in pregnancy, remember, we are going to increase our volume, 30 to 40% by the last trimester. Well, take a look here. Signs of shock may not appear until 30 to 40% of blood volume is lost. So you have to really be in tune to what's going on and catch this before it gets out of control. On page 729 in your text, there is a beautiful schematic diagram that takes you through the bleeding and the nursing assessments for, what's going on with this. When the placenta is delivered, if the placenta is retained, do you suspect a coagulopathy? And it takes you through a flow chart diagram of exactly what to do. Now, a lot of it is what we've talked about through, these slides. I mean, we're on 15 now, so the slides that we've talked about, but it puts it all on one page for you. So go and take a look at that. All right, so medical management when you have a hemorrhagic shock. Well, we have to restore the blood volume. For every packed unit of red blood cells, you're going to replace about 450 milliliters of blood volume. So you stop and think about almost any time packed red cells are ordered, you're going to have 2 units. So that's 900 cc's of blood that I'm putting back into her. Okay. Remember we said that for every 500 milliliters of blood loss, your crit drops 3%. So I'm kind of getting that crit back up. So you want to restore circulating blood volume. Just a little note. You want to make sure that about every 2 units of packed red cells you give, you're wanting to give a unit of fresh frozen plasma to kind of balance that out. You also need to make sure that you have identified the cause of the hemorrhage and that you're treating the cause of the hemorrhage, however that may be, whether it's with medications or surgical interventions. From the nursing perspective, frequent assessments. I mean, this is somebody who is going to, have oximetry going. They're going to have continuous vital sign monitoring. They're going to be having neuro assessments done for cognition and just neurofunction. And I've told you that looking at urine output is such a great parameter of assessment for perfusion, because if you are putting out 25 to 30 cc's an hour, then you have to presume you are perfusing your kidneys, you're not shunting fluid away. Most Foleys just have a collection bag, but there is something called a urometer, which will actually give you very specific urine output amounts so you can get a Foley with a urometer that's attached to the drainage collection bag, and you will be able to easily identify how many milliliters are they putting out instead of just having those lines on the bag. So if you notice, I've said about 3 times, adequate urine output is 25 to 30 milliliters an hour. Anything less than that, we have varied issues and concerns about. As a nurse, you are going to be the one administering the blood, so you need to make sure that you've got the consents in place. You need to go through your safety checks to make sure that the product you are about to infuse is actually appropriate to the patient, that all of the identification matches up. She may need oxygen because remember, she's hypoxic. Loss of volume, so we want to give her oxygen to support as much as we can, and as I said, she will be continuously monitored and the telemetry will be in place. Alright, so we've had our hemorrhage event, we've identified it, we have treated it, we have managed it, now she's stable. What are we going to do to keep her that way? She's probably going to need some assistance with ADL. She may be very weak and tires easily, so you want to help her out there. She may not be very hungry at all after this, kind of understandably so. So when she does want something to eat or drink, you need to make sure that it is appropriate and that it has the appropriate nourishment factors in it. You want to keep her hydrated, but you also want to keep good solid foods in her. Make sure that you are educating her about foods high in iron and that you remind her to please keep taking her prenatal vitamin with iron. A sad reality is most women either don't take their prenatal vitamin during pregnancy or they quit taking it towards the end of the pregnancy. They definitely leave it at home and don't take it once they've had the baby because they're like, I've had the baby, I don't need it anymore. This woman needs it. Okay, so you want to encourage her to keep taking vitamins with iron. Tell her how to change position slowly, how to maybe sit up on the side of the bed, dangle her feet a little bit, stand up slowly, maybe even holding on to something, things to minimize that orthostatic hypotension that can happen. If she is getting antibiotics and she's going to go home on antibiotics, you need to give her education to make sure she takes them as ordered. People are notorious for taking their antibiotics 2, 3, maybe 4 days, and then their symptoms disappear, and they're like, oh, well, I'm already cured. I don't need to finish this. And that's how we get the multi-drug resistant organisms, because we expose these bugs to medicine for just enough for them to identify it, mutate against it, and then when we try and use it again, it doesn't work. So she needs to take all medicine as prescribed completely until it's gone. And then the education that this was a hemorrhage event. So if she is still, a childbearing aged woman and plans on having other children, then this needs to be part of her knowledge base to share with her next OB provider that, yes, I did indeed have a hemorrhage event. Not all women know that's what happened. So we need to make sure that she understands what happened, what it means, and what we can do to hopefully minimize this from happening again in the future. ITP, which is also known as either immune or idiopathic thrombocytopenic purpura, is a rare bleeding disorder that's characterized by a low amount of platelets in the blood. In patients that have ITP, what happens is the person's own immune system will create antibodies that will mark healthy platelets as foreign substances, and so then they'll attack the platelets and destroy them. As an autoimmune disease that results in the destruction of platelets, patients that have ITP will obviously bleed easier and bruise easier. What you will see diagnostically in these patients will be low platelets and increased bleeding times. Now, if the bleeding that you have seen and that needs treatment is significant, they'll treat with platelets. If the bleeding is severe or unresponsive to therapies that are given, the patient may wind up having a splenectomy. In looking at your von Willebrand disease, that's an autosomal inherited congenital bleeding disorder. It's not very common per se, but among women, it is probably the most common congenital clotting defect in the United States for childbearing women. So it definitely plays an important role in bleeding and postpartum complications. What you have is a deficiency in von Willebrand factor. Von Willebrand factor is a protein that's necessary for platelet adhesion and protection against coagulation factor degradation. If you have von Willebrand disease, the treatment of choice is going to be desmopressin, which kind of aids in the release of your von Willebrand factor and your factor VIII for clotting. You will give the desmopressin either by mouth, you can give it IV, or you can give it nasally. If you have a patient with von Willebrand disease, it's going to be really important to remember that she's going to be at risk for bleeding and hemorrhage event up to 4 weeks after she has the baby, just in association with the von Willebrand disease itself. Two conditions seen in pregnancy and postpartum are hypercoagulability and venous stasis, both of which contribute to the development of thrombus formation or thromboembolic disease. Now, other contributing factors to think about are going to be smoking, the age. Is she advanced maternal age, over 35? Is she a multip or a grand multip? What was her birth? Was it an operative or assisted vag delivery? So do we have to use forceps or a vacuum? And then commonly, everybody knows about immobility. If you're not moving around, that's venous stasis in and of itself. So because of that and immobility being such a big deal, one very effective measure that we've implemented in the recent past that will help offset the immobility or stop the immobility really is nothing more than just getting them up and moving them around. Early ambulation. I mean, we preach it a lot. If your patient has had a cesarean birth, not only are we doing the early ambulation, but she will have SCDs, the sequential compression devices, put on her lower extremities or her calves while she is in the operating room. If a thrombus does form, you can kind of classify it as 3 different ways: superficial, a deep venous thrombus, or a PE. Superficial thrombi are your most common in postpartum. You're going to see pain, tenderness, warmth, redness. The site will have enlarged hardened vein there. Your DVTs are more common in pregnancy and may not always be easy to identify. You got to think about pregnancy masks a whole lot of things, and there can be more than one cause for what you do see. So if you have this, what you can expect would be unilateral leg pain, swelling of the leg or the calf, and tenderness. A positive Homan sign may be present, yet you really don't need to just stop there. Go ahead and do some further assessment, because you need to make sure that there are not any other causes that can be attributing to the pain. If it's a lower leg calf pain, did she strain a muscle or something? So go ahead and do a full assessment with that. If you get the patient with a PE, they're going to be tachypnic, they'll have dyspnea, so it'll be hard for them to breathe. They'll be breathing fast. Their heart rate's probably going to be a little fast. You got to think about there's probably some hypoxia going on. So they're going to be anxious. If they're not able to breathe air in, a natural body defense to clear the airway is to cough. So you'd see some cough. The pleuritic chest pain, that's going to be a sign because you got the embolus in the lungs itself, pulmonary embolus, okay? Invasive testing for any of these will be venography. It's, kind of has some complications going along with it because it is invasive, so it's not always our go-to. More commonly, you're going to do the non-invasive, either real-time or color Doppler ultrasounds. All right, so management. If it's a superficial thrombus, analgesias, your non-steroidals will be pretty much your go-to. You're going to rest the extremity, elevate it. The compression stockings, you'll have them wear those. If it's a DVT, they're going to need anticoagulant therapy. Initially, they're going to start off with IV heparin. Once they get symptoms under control, they'll probably transition the IV heparin onto the PO warfarin. If it is a PE, they're going to be on continuous IV heparin until the symptoms resolve, and then they'll go to sub-Q heparin, or they'll use the warfarin for up to about 6 months. So you'll be doing labs in the hospital. You'll be looking at PT, PTT. You'll be doing your assessments on these patients. Are the symptoms getting any better? So you'll be checking for swelling, for pain, tenderness, redness. You want to make sure a thrombus doesn't become an embolus. So if they've got a DVT, you certainly don't want it to progress to a PE. You'll be doing your assessments of the lungs, listen for lung sounds, any diminished, any crackles. Are they experiencing chest pain? Are they having dyspnea, tachypnea? Are they anxious all of a sudden when they weren't before? So you'll need to be doing those types of assessments. If you've got a woman who had a DVT and she's being discharged home and she's breastfeeding, she wants to know, is it okay to continue breastfeeding? Yes, by all means. Neither heparin nor warfarin are significant in breast milk, so there is no contraindication to breastfeeding with these medications. You will need to make sure she understands, don't take anything like aspirin. I mean, we're already giving something to prevent clotting. We don't want them to have aspirin on top of that, because aspirin is going to prevent clotting, promote bleeding as well. And you need to make sure that their diet, that you give them instructions on what foods they need to stay away from. You know, your green leafy vegetables, things that are going to enhance clotting, we want to stay away from that. All right, so postpartum infections. Puerperal sepsis is another word for postpartum infection. It's pretty much any infection of the genital canal within 28 days of abortion or birth. Now, in the United States, postpartum infection has been defined as a temp of 100.4 Fahrenheit, which is 38 degrees Celsius, for 2 or more consecutive days, not within the first 24 hours of birth, because remember that first 24 hours everything is kind of inflamed and elevated. So if she has a temp 100.4 or more, 2 or more days after the first postpartum day, then we're thinking postpartum infection. Postpartum infection is 10 times more common after a cesarean birth, and this may really depend on the risk factors that were associated with why are we operating, you know, or what protocol for prophylactic antibiotics may have been in place. There is evidence that the prophylactic antibiotics reduce the risk of endometritis by 65 to 75%, which is pretty good. Y'all may all remember seeing them use betadine and swabbing the vagina and the perineum. Well, the thought is that that will decrease the risk as well. Endometritis is the most common cause of postpartum infection, and the most common causative organism of endometritis will be your streptococcal or other anaerobic organisms. The number and the severity of the symptoms can vary markedly from patient to patient, but generally your symptoms are going to include fever, abdominal pain, you know, a foul-smelling lochia, abnormal vaginal bleeding. Remember, infection and postpartum hemorrhage go together. An abnormal vaginal discharge. They may have dyspareunia or dysuria, and just general malaise. Okay. Now, clinical signs will be the temperature that we're talking about earlier, and pain and tenderness in, you know, the pelvic, lower abdominal area, and the pain may radiate to the adnexa, over to where the ovaries are. And she will have tachycardia. Remember, fever, tachycardia, those go hand in hand. Now, some women will have a foul-smelling lochia without any other evidence of infection. So if you have a foul-smelling lochia, you have to think, okay, infection. But some infections, and most notably infections caused by group A beta hemolytic strep, those are frequently associated with scanty and odorless lochia. So just keep that in mind. Group A strep, lochia scant, and odorless. Wound infections occur in women at home, and those are usually associated with, you know, your cesarean incisions, your episiotomies, or your lacerations. So, you know, you want to talk to them about good hygiene at home, perineal hygiene, sitz baths can be done, warm compresses, because we want to make sure that we increase circulation to the area. And that, you know, we let the body's natural healing things take over, you know, so you get your white cells in there, you clean everything out. Urinary tract infections, you may see those. Pretty much E. coli is going to be a common thing, so that goes into the genital hygiene, you know, when they're changing their peri pads, you know, change them, you know, front to back, not back to front, wipe front to back, not back to front, that kind of stuff. Things that happen in the hospital that could promote the development of a urinary tract infection after the fact Doing the Foley on her, whether it's an indwelling Foley or an in and out cathing, that can obviously put her at risk for a UTI. Urine retention or ineffective bladder emptying. Think about the woman with the epidural. She may not feel the urge to get up and go to the bathroom or to empty her bladder. Or she could have had an injury during having the baby. If it was a cesarean birth, did they do something to the bladder then? If she has a urinary tract infection, she's probably going to get some antibiotics. The same way we talked about the importance of antibiotic management with a hemorrhage, the same thing goes with any time you get antibiotics. Make sure she takes them correctly and completely. Mastitis. Now, we talked about mastitis, pretty much in detail whenever we did the postpartum chapters. Make sure that you review just what causes the mastitis. What are you going to see? It's usually unilateral, that pie wedge redness shape. She's going to be fevered, kind of malaise, chills, achy. She needs to be encouraged to continue to breastfeed. That's not a reason to not breastfeed, and she needs to make sure that she takes her antibiotics. All right, so as if having a baby in and of itself wasn't enough for us, there can be trauma or side effects related to the changes that we go through when we're pregnant and having the baby that stay with us. Disorders of the uterus and the vagina that are related to pelvic relaxation and urinary incontinence are associated with the sequelae of childbirth. These are often because of childbearing, yet you may see these conditions happen in women who have never even been pregnant. One of the big first things that we have to deal with is uterine displacement and uterine prolapse. Now, the most common uterine displacement is going to be retroversion. However, retroflexion and anteflexion can be seen as well. So, kind of just in definitions, retroversion is a condition in which the fundus is kind of tipped backwards. With anteflexion, you're going to have the body of the uterus bent sharply forward, kind of at junction of the cervix. Retroflexion is going to be a condition in which the body of the uterus is bent sharply backwards. Now, when you're talking about uterine prolapse, that's going to be much more significant. You think about displacement as just moving. Well, prolapse is actually when the uterus kind of falls out. The cervix up into the actual body of the uterus will protrude through the vagina to outside of the body. We use the term procedentia as a marked prolapse. Depending on the degree of the prolapse will kind of determine what associated discomforts and symptoms are going to go along with that. Things that can trigger a prolapse, somebody, if they're straining, bearing down, anything that increases the intra-abdominal pressure will push down and force the uterus out. But something as simple as prolonged sitting can actually potentiate the action and the effect of a prolapsed uterus. The weakened pelvic floor, the structures, the muscles just can't contain the uterus in the position that it needs to be, whether it's just repeated pregnancies, heavy pregnancies, large for gestational age, macrosomic babies, whatever. It's that stress on the pelvic floor and those support structures that the end result is not able to hold the uterus in, and then you have the prolapse. So this is simply one of the figures out of your book that shows how a normal uterus should sit positionally inside the pelvic vault. And you can see the uterus starts almost standing up and puts it more in a descent line And then a slight prolapse is just where it's slightly coming down, but you can get all the way through to a marked or even a full prolapse uterus, where you've got the cervix, the cervical neck, and even the body of the cervix protruding through the introitus to the outside of the body. Now, your cystocele and your rectocele, usually you see those in association with a uterine prolapse, and they can actually exacerbate and worsen the prolapse of the uterus, making it go even further backward and down into the vagina. Your cystocele is a protrusion of the bladder that it goes downward into the vagina. All right, so the support structures and the vesicovaginal septum are injured. So whenever she bears down, you will see the anterior part of the vagina, so right under the bladder, that will herniate down. You'll see it bulge down. Rectocele is a herniation of the anterior rectal wall through relaxed or ruptured vaginal fascia and the rectovaginal septum. So with the bearing down, if it is a rectocele, then you'll see the bottom, the floor of the vagina, which is the anterior rectal wall, herniation push up. So you can have her bear down, and that will be able to show you, is it a cystocele or is it a rectocele? While your cystocele and your rectoceles are, for the most part, asymptomatic, what the woman may complain of is just feeling that something is down there, something is sticking out, or she has a fullness in, in the vagina. Bearing down, something just doesn't feel right. She may be going to the bathroom often, maybe voiding a lot, maybe unable to control the voiding and having some incontinence with that. On a pelvic exam, you may feel either a bulge anterior or posterior. With a rectocele, something as simple as having a bowel movement can be uncomfortable or sometimes even challenging for patients, with the strain and the bearing down to express the feces. That actually can push, the stool up against the herniation and progress it even more. One intervention that women sometimes enact is to simply facilitate removal of the stool by putting digital pressure vaginally. So sticking the finger up inside, holding it against that herniation so that when they're straining, the feces can't push against the herniation. It's able to evacuate more easily. Stress incontinence is something that can happen just from, the weight of the fetus. Again, we learned about that in pregnancy, that people laugh, cough, or sneeze or something, and sometimes a little urine leaks out, and that's just because there's so much pressure put on the bladder and put on the support structures to hold the urethra up, hold the bladder up, that the pressure, anything that puts tension against it, just causes involuntary leaking of urine. That's going to be a classic sign of it. So, you may hear women say, every time I cough or sneeze, I kind of wet my pants a little bit. That's associated with that. Interventions, depending on the age of the patient and everything, can be something as simple as trying to repair the vaginal tissue, strengthen it back up. If they're estrogen deprived, then you may use a little topical estrogen. Some people actually have surgery. You may have heard about the meshes and the slings to try and support the bladder to offset the incontinence. For your genital fistulas, these may result from a congenital anomaly. It may be from GYN surgery, OB trauma, radiation therapy, GYN trauma, or even infections. The fistula gets its name depending on what structures are associated with it. So your vesicovaginal fistula, this is the fistula tract between the bladder and the genital tract. Your urethrovaginal is between the urethra and the vagina. Your rectovaginal, rectum or sigmoid colon, and the vagina. You can pretty much determine what's where and what the tract is by what you see. If you see urine or feces in the vagina, or if gas is passing through the vagina, that's going to cue you in onto where your fistula is occurring. On the next slide, I've got, it's really just the image out of your textbook, but that actually shows you how you can see where the fistula tract occurs between the internal structures. So here you see 6 different types of fistulas. You've got your vesicouterine, which is your bladder uterus, your urethrovaginal, which is from the urethra going into the vagina, your perineovaginal, which is a tract that's actually from the vagina, but it is exiting not at the introitus, but in the perineal space, your vesicovaginal, your rectovaginal, and your vesicocervical. Those are all different fistula formations. You should be able to, if you were given one, based on the name, be able to tell me what structures are associated with that. I kind of talked a little bit about treatment and surgical intervention with each issue as we went through it, but just in general, your care management, a lot is going to focus on what the condition is and really the severity of the condition and what impact it has on that individual's quality of life and her ADLs. You know, what education does she need, you know, hygienically, management, you know, what can exacerbate it, what makes it better. There's going to be, you know, assessment for the problems related to structural disorders of the uterus and the vagina. You know, if she has, you know, a rectovaginal fistula, can you imagine the psyche, that disruption that she may have with that, and just the embarrassment, and then the hygiene issues and the potential infection issues. So you're going to need to keep that in your mind. You know, I've always told women, you know, not to douche because douching can actually hurt the vaginal flora because it washes away all your good lactobacilli, you know, your housekeeping organisms. However, depending on what's going on, and if they have a pessary in place or something, you may need to do some douching. So you say pessary, well, what's a pessary? A pessary is actually a good little support structure that a woman can use, some for a limited time, some for a little bit longer time, but management of that is going to be very important. Now, what the pessary is simply a fitted device that is inserted into the vagina, and it supports the uterus and helps hold it into position and can kind of keep everything else lined up the way it needs to be as well. But it is a device, so you got to think about those are delicate tissues. If you have a device in there that's not fitted properly, worn incorrectly, or worn for too long, you can actually have necrosis from it, which is not going to be very good. And again, you can have a vaginitis, inflammation, or infection that's associated with that as well. The estrogen therapy will kind of help with erosion because it strengthens that vaginal tissue. And again, making sure that you're taking it out, you're cleaning it, and that you are managing it well, wearing it appropriately is going to be very important. With your cystocele, rectocele, urinary incontinence, anything like that, as we said, surgery may very well be an intervention to correct those defects. Kegel exercises, we were preaching that almost from day one, that you want to keep those pelvic floor muscles toned and those structures toned and active and kind of resist the effect that the pregnancy weight has on it. So you definitely want to have them doing their Kegels. So what you see here are just different types of pessary devices. The silicone ring down at the bottom left is one that I've kind of seen utilized more often than not. The ring that's in the top right corner kind of is utilized with it as well. This is something women, it's a very stiff plastic, so it's not like the contraceptive ring that you can easily press between your fingers and put in. This is a lot stiffer. You do need to use lubricant to be able to put it in, and it's a practice kind of thing. If you have an older aged woman who is using this, she may not have the hand strength to be able to hold it together to put it in, or it may keep flopping open on her. That can be very uncomfortable, so she may be less likely to want to take it in and out for cleaning or anything. Some providers will actually just have standing appointments for patients to come in to be able to have it removed, have it cleaned appropriately, make sure they're not having any infections or inflammations, and then they will put it back in for them themselves. Mental health disorders in postpartum have the potential to interfere with maternal attachment to the newborn as well as family integration. These complications may actually threaten the safety and well-being of the mother, the baby, or any other children or family members that are in the family. While it doesn't surprise us to say that most all, if not all women, may experience a quote unquote mild depression, which really is a misnomer for the baby blues, being declared as a postpartum depression is a little bit different, okay? Remember, with baby blues, a little bit of rest can fix that. Rest is not going to be able to fix this. Now, your DSM, your Diagnostic and Statistical Manual of Mental Disorders, that has the guidelines for assessment and diagnosis of your psychiatric illnesses. But specific postpartum depression criteria aren't listed. What they do is look at the onset of it. If you have any type of psychosis or depression that occurs within 4 weeks of childbirth, then you're going to either classify it as a mood disorder without psychotic features or with psychotic features. So it will simply be a postpartum depression or a postpartum psychosis. As far as the root of postpartum depression, there are different things that they attribute it to. Biological, psychological, situational, or even a combination of those things may be your causes. 13% of women will develop a more serious depression, so that's a pretty significant thing we need to worry about. Postpartum depression has many different levels, and it can actually be a devastating and, for the time, debilitating kind of disease process that makes them incapable of caring for themselves or for others. So if you have just, for lack of a better word, a straight postpartum depression, you shouldn't expect the psychotic features. With a postpartum depression, you're going to have just an intense, pervasive sadness with severe and labile mood swings. Management of this is going to be probably a combination of things. You really always need to have psychotherapy for these individuals. I think with any mental illness, there's two parts of it. There's the medical part of it, and then there is going to be the psychological part of it. So you need to have that psychotherapy. Really, you want to focus on, fears and concerns that she may be experiencing. As far as being a new mother, the roles and responsibilities. And she may have more than one kid, but it's a new mother to this one child. You always, with any kind of depression, want to make sure that you are assessing for the possibility of suicidal or homicidal ideations. Remember, one big fear and concern that we have is injury to herself or to others. So something you definitely need to look at with that. Um, Medicinal treatments that you're going to be utilizing will be your antidepressant medications, your anxiolytics, and depending on the severity of it, maybe even ECT. We'll talk a little bit about the medicines on the next slide. When you are dealing with postpartum depression with psychosis, this is a syndrome characterized by depression, delusions, and then this is where thoughts of harming either the baby or herself come into play. So you notice I've got this underlined and defined. Psychosis, you have the thoughts of harm for either self or to the baby, okay? If the woman experiences a postpartum depression with psychotic features, there's a 30 to 50% likelihood that subsequent pregnancies she will experience the same thing. So that's kind of significant in your planning and your counseling with this person. If you are having the intent to cause harm, okay, a lot of times it's going to be the infant that is going to be kind of more at risk. If you have auditory hallucinations, they may command the mother to kill the baby. With delusions, the mother may think the infant is possessed by the devil or has special powers or something like that. So if you have a woman who is showing these psychotic features, this may require commitment. So she's probably not going to want to go and do it herself. She's probably going to be admitted to a psychiatric hospitalization for continued, line of sight surveillance. Your antipsychotics and mood stabilizers, such as your lithium, that is going to be your treatment of choice with postpartum depression with psychotic features. So remember, harm to self or the baby, more than likely it's going to be associated with the baby, and it is a psychiatric emergency. They do need to be monitored under constant surveillance. All right, so if the woman is not breastfeeding, medications can be prescribed without special precautions or considerations. However, if she is breastfeeding, we do need to stop and think for a minute. We know the meds do cross into the breast milk, but that in and of itself is not always a reason to either stop breastfeeding or to not breastfeed at all. Medications that have a short half-life or medications that are protein bound may not have as high of a concentration or a risk as those medications that have a longer half-life. So they have the ability to be present in the breast milk longer. So you've got the risk for neonatal infant ingestion and accumulation of the medications. So because of all this, you need to look at risk and benefits to the mother and the infant, weigh those out against each other when you're considering, do I breastfeed, do I not breastfeed, and maybe even what medicine am I going to look at. I want to take a look at at the psychotropic meds and kind of each class that we're talking about. Your selective serotonin reuptake inhibitors, or your SSRIs. They're used more frequently than any of the other meds because they're safe and they really have fewer side effects. Your tricyclic antidepressants, or your TCAs, a common CNS side effect that you see with those is sedation. That can actually pose a significant safety risk. Think about the mother who, is on one of those medications and she falls asleep holding the baby and drops the baby, or, she's feeding the baby and the baby chokes or something. So there's a big concern with that. She may also have anticholinergic side effects that just make it unpleasant for her. She can be sweating, have dry mouth, constipation, difficulty voiding. Those are not pleasant side effects, and that could make her not want to choose that or be adherent to the dosing regimen. With your monoamine oxidase inhibitors, your MAOIs, the predominant concern there is going to be hypertensive crisis. And that's one of the main reasons we don't use this group very much. If a woman is on an MAOI, she needs a lot of education about blood pressure surveillance and control. Other medications that are utilized in postpartum depression would include your mood stabilizers, anxiolytic meds, and your antipsychotic meds. Now, most of your antipsychotic meds will cause sedation, orthostatic hypotension, your peripheral nervous system and central nervous system side effects, and some of those can even be fatal. In regards to all of the different medications, because there are a lot of them, what I want you to do is just review the table in your book. I think it's on 747. You can see the individual medications listed out. Actually, what they're doing is looking at the lactation risk for them, but you can see the names and kind of get an idea of what falls into what group. What is going to be important to remember is what the different groups are, which one is more commonly utilized, and what would be some of the considerations that we need to think of whenever we are prescribing these medications. What kind of education do we want to give the mom and stuff like that. I said that medications aren't the only things that we need to do whenever we're managing and treating these patients. So there are, sometimes the homeopathic things, and I'm just talking about holistically looking at the whole person, stress reduction, helping her, find herself, helping her stay calm and in tune with maybe her emotions and what she's thinking and feeling. Our psychotherapy can do that. But stress release, exercise, eating a well-balanced diet, making sure she gets rest, yoga, meditation, all of those are interventions that have multiple benefits. It can help her not only psychologically, but it can also help her physically. So that's chapter 23, postpartum complications. Listen to the lecture, see the notes, read through the book, and any questions you have, bring them to class on Monday.